Good evening, everyone, and thank you for joining us for tonight's International Dermatology Education Foundation Educational Series webinar. My name is Ashley with RBC Consultants, and we are looking forward to bringing you tonight's webinar titled The Latest Approved Indication for COSENTYX. As moderator this evening, we have Dr. Leon Kircik. He is president of the International Dermatology Education Foundation, clinical professor of dermatology, Icahn School of Medicine at Mount Sinai, New York, adjunct clinical professor of dermatology at Indiana University School of Medicine in Indianapolis, Indiana, and medical director of physician skin care, DermResearch, and skin sciences in Louisville, Kentucky. As speaker this evening, we have Dr. Stephen Daveluy, Associate Professor and Program Director, Wayne State University, Dermatology. We would like to thank our supporter this evening, Novartis, for making this educational event possible. Before we begin, a few logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane, and the dial-in information will be displayed. If you're having technical issues, please submit your questions in the question pane on the right-hand side of your screen. At the end of the webinar, a survey will pop up in your browser and it will be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill in this short survey. And finally, within 1 to 2 days of the webinar, you will also receive a certificate of attendance. It will be emailed to you. We will have a Q&A at the end of the program, so please submit your questions using the question pane on the right-hand side of your screen. Now, without further ado, I would like to pass the floor virtually to Dr. Kircik.
Thank you, Ashley, and good evening, everyone, and welcome back. We were just here last night at this time. So tonight, as usual, I am moderating rather than I am speaking. Before we go to our program today, I'd like to tell you a little bit about International Dermatology Education Foundation. IDEF is a nonprofit organization whose principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. And since pandemic, we're coming to you and bringing a lot of webinars, almost twice or sometimes 3 times a week, such as this week, to all over the world, not only US, but also Canada, South America, as well as Europe and Southeast Asia, as you can see from some of our programs invites here. Tonight, we are very lucky to have Dr. Steve Daveluy. And by the way, don't forget to follow us at in Facebook and Instagram and LinkedIn. As I mentioned tonight, we are very lucky to have Dr. Steve Daveluy by way of Canada through Detroit. He is the assistant professor and program director at Wayne State University Dermatology, and he's gonna tell us all about the latest approved indication for COSENTYX secukinumab. Take it over, Steve. Thank you so much, and I appreciate you joining us tonight.
Thanks for the kind intro, Dr. Kircik, and thank you everybody for joining. I'm always excited and happy to talk about HS, and very happy tonight to talk about COSENTYX and the data for HS and what we know about this treatment that's been approved for just over a year now, because it was October of 2023 that it was approved. So hopefully you've had some experience with it, but we'll really deep dive into some of the data tonight. These are kind of the topics we'll talk about, and we'll start with the patient burden. I probably don't need to tell anyone who treats HS how understudied, underdiagnosed, and undertreated it is. We think about 1 in 100 people have HS, but our estimates for prevalence are really difficult because there's so many people undiagnosed and delays that is probably an underestimate. And if you're like me, you've been seeing more and more people self-diagnosing, looking things up, or even coming back to the clinic after they haven't been treated for a while because they sort of gave up on the healthcare system, but now they're hearing there are new treatments and coming back to sort of give us another chance. So we know it's a chronic systemic inflammatory condition, and really the characteristic lesions are painful nodules, abscesses, and tunnels in the skin. And that pain is really an important piece. And about 97% of patients experience physical pain, and we know from surveys that's often the thing that brings them into the healthcare system is the pain from their lesions. And one of the important things in HS is that it does cause irreversible skin damage, scarring, and pain that has a big burden and really emphasizes the fact that we need to kind of shut the process down sooner. So we need to think about it like we do with acne, where if we see scarring, we try to cure you as soon as possible to stop the scarring. And we believe starting a biologic treatment prior to the development of irreversible tunnels and scarring can improve those outcomes. We sort of talk about a lot now the window of opportunity, that we need to treat these patients before the disease gets very advanced, because it's much more difficult to treat when it's more advanced, which you've probably all experienced. So we're going to talk about COSENTYX, which is approved for adults with moderate to severe HS. And we'll talk first about its 17 years of experience with COSENTYX. So it's not a new drug, even though it's relatively new to HS. It's been around for 17 years in trials, over 9 years on the market, probably over 10 years on the market now, and over 4 million prescriptions dispensed in the US. And they have Novartis has a great patient support program to help get your patients on drug, assist with copays and getting started and keeping them on drug, because we know there can be a lot of insurance hurdles when it comes to getting medications approved and actually getting your patients access to what they need. This shows the timeline for COSENTYX, where we see it started in 2015 with moderate to severe plaque psoriasis, and then we added on psoriatic arthritis and ankylosing spondylitis, and then axial spondyloarthritis. And then the plaque psoriasis indication went down to 6 years and older, from adults down to 6, which is great. And in 2021, it also got approved down to age 4 for enthesitis and 2 for juvenile psoriatic arthritis. And even though in HS it's approved for adults, sometimes it's reassuring to have that data and say, you know, it's approved down to age 2 or age 4 and other indications for those patients who are a little bit leery about side effects or a little nervous about starting a medication. So even though it's not approved for that age in HS, I still sometimes have that conversation with patients, because it helps them to feel a little reassured that if the FDA approved it for children, then there's got to be some good safety data. It is the first and only FDA-approved IL-17A antagonist for adults with moderate to severe HS. And we'll dive a little bit into why we think that's important. We can't officially say that because it's really hard to show exactly why something's doing it, but we'll talk about the pathophysiology and why it makes sense that IL-17A is an important target. So they did some studies where they took biopsies of lesional skin and perilesional skin in HS, or sometimes they would use excision specimens where you cut out a big area of HS, and they found that IL-17A is elevated both in the lesions and in the perilesional skin. So we'll take a little deeper dive here. We see the HS in this typical patient and then in the axilla. So looking down kind of inside the skin, we believe that the first step in the pathogenesis is follicular hyperkeratosis that results in occlusion and sort of starts that inflammatory cascade. And you can see at the bottom, there's a little key of the different inflammatory players that are involved here. And the sort of orange cheese puff looking things are our IL-17. You can see they're elevated both in the lesions and around the lesions, so the perilesional tissue. The next step is rupture of that follicle, which of course then really activates the immune system much, much more. So we're seeing now again that IL-17 within and around. And then with time, this leads to this chronic inflammatory state where we see scarring and tunnel formation. And we still see that IL-17 is a big player in this inflammatory milieu that's sort of surrounding them. So then in comes our COSENTYX or secukinumab, which is this big pink antibody. And you can see it's selectively binding to IL-17A. So that way IL-17A can't interact with its receptor, which is how it has its downstream inflammatory properties. So as I said, we believe this is why it's able to help treat HS, because there is IL-17 elevated in the inflammatory milieu around HS lesions and within them. And so blocking that helps to stop that march forward of the inflammatory process that we see in HS. So let's talk a little bit about how does it work in HS and what evidence do we have. The trials that got COSENTYX the approval for HS were called Sunshine and Sunrise. Together, we call them the Sunny trials to kind of abbreviate. And they were the largest ever phase 3 clinical trial program for HS that included over 1,000 patients. You can see, as I mentioned, it was over 1,000 patients across 219 sites across the globe from January 2019 through July of 2022. We'll talk a little bit about the trial design, where the primary endpoint was at week 16, but then they continued for 1 year of follow-up to continue monitoring for safety and efficacy. And again, included adults with moderate to severe HS. So these cover the inclusion and exclusion criteria, and these are pretty standard for HS trials right now. So as I mentioned, it's for adults with moderate to severe disease. Moderate to severe disease could be early stage 2 or 3, as we often sort of use that as a surrogate of mild, moderate, severe. But I always make a point when I talk about HS to anyone to point out that you can actually have severe or moderate disease that's not early stage 2. And so the other way that we borrow from another tool that we don't use as much in US trials, but in European trials, is called the IHS4. And the IHS4 defines moderate disease as at least 5 inflammatory lesions, which are your abscesses or inflammatory nodules. And the reason this is something I kind of hone in on a lot is to point out to people that if you see a patient who even has earlier stage disease, like maybe it's still early stage 1 and they don't have tunnels forming yet, but you are seeing 5 or more inflammatory lesions at the same time, that's moderate disease. And that does predict that they're probably going to progress. And so you don't want to delay sort of waiting for a tunnel to show up. The other caveat I always mention with early staging is I have very, very rarely seen early stage 1. Technically, early stage 1 is migratory lesions, inflammatory nodules and abscesses with no scarring and no tunnels. And it's really rare that we see an HS patient with no scarring. Often, even their first lesion might lead to a scar. So I think a lot of people in practice look more for the tunnels and call that early stage 2 when they see a tunnel, but the tunnels aren't all taking over an area. There's still some normal skin between them. Occasionally, you do see a early stage 1 patient, and those are sometimes the patients where you're like, I'm pretty sure you have HS, but it could be something else, but let's treat it like HS and keep close follow-up. But I just want to point that out to people, that if you can kind of judge the patient's inflammatory burden, and if they have at least 5 inflammatory lesions when they're seeing you, that's moderate disease, and it's time to really kind of stop the disease process before it progresses. They were required to have lesions in at least 2 distinct anatomic areas, so that could be left and right axilla or left axilla, right groin. As you may guess, with HS patients, most had involvement bilaterally of multiple areas, and they had to have a diagnosis for at least a year prior to baseline. And so that's just, again, to sort of make sure it's a certain diagnosis. That's one of the criteria that we're sort of pushing to change for clinical trials, to diagnosis for a year, to change it to disease for a year, because sometimes, as you know, with HS, patients will come in and go, well, I just got my diagnosis, but this has been going on for 5 years. So we're really changing that criterion to be disease for 1 year because of the misdiagnosis. And then stable treatment with tetracycline class antibiotics were allowed for a group of the patients, and we'll kind of talk about that group a little. And previous treatment with TNF inhibitors was allowed. So there were patients in there, which was really important because we know adalimumab was the first drug to market with approval. And so when COSENTYX hit the market, a lot of us were thinking about our patients who were not doing so great on adalimumab, and we were thinking about switching. They had to have exclusion criteria. You had to have it less than 20 fistulae, which is just because in severe disease, it's really hard to measure a response. Pregnancy and lactation, other diseases that would interfere, and then prior exposure to IL-17s. As I mentioned, the first 16 weeks were the placebo-controlled period. They tested both dosing regimens of Q4-week dosing and Q2-week dosing after the standard weekly 5 loading doses. And the primary endpoint at week 16 was the HiSCR 50. They also looked at some secondary endpoints, including the AN50, which is just the abscess and nodule count, which we'll talk about the difference between that and HiSCR, the proportion of patients with flares, and the skin response, which was a 30% reduction in their pain NRS. Then after that 16-week period, the placebo patients got to re-randomize into one of the COSENTYX dosing. And we'll talk a little bit about where we re-randomize at week 16 because it's cruel to make someone stay on placebo longer than that. But actually, all of our drugs in HS, we know that's not where they peak in their efficacy. So we'll show that when we get to sort of the results. And then at the 1 year mark, they follow patients out to week 52, a full year. They looked at high score 50, which is 50% improvement, high score 75, 90, and 100. Again, the AN 50 count, the flares, the NRS 30, which is that 30% reduction in pain, and quality of life as measured by the DLQI, the Dermatology Life Quality Index. You can see at baseline, the patients were pretty typical HS patients. The majority were under 40, were female, had a weight of greater than or equal to 90 kilograms, and a pretty good mix of different races and ethnicities. And then you can see they were all, because this trial specifically did require them to be early stage 2 or 3, you can see a small majority were early stage 2, but quite a few early stage 3 patients, a lot of patients that had previous surgery. And then we can see at the very bottom, the exposure to systemic antibiotics. So most HS patients do get antibiotics at some point. And overall, about 24% or almost a quarter had been treated with an anti-TNF biologic. So we'll talk about that a little bit because, like I said, that's who we're kind of thinking of right out of the gate, those patients who needed something. So the high score 50 is a 50% reduction in your abscesses and inflammatory nodules compared to your baseline. But there's 2 disqualifiers. If you have an increase in your abscesses or an increase in your draining tunnels, you don't qualify as a high score 50. So it's a little bit of a stringent criteria. The idea is to make sure people aren't just sort of progressing by having fewer lesions that consolidate, but it creates some challenges for us with the high score. So you can see in the Sunshine and Sunrise trials at week 16, 41.3% and 42.5% of patients met the high score 50 or 50% or greater reduction, at least a 50% reduction. This shows it again in a graphical representation up to week 16, where you can see the scores for each of the Sunny trials and then the placebo group from each Sunny trial. And you can see that the COSENTYX outperformed the placebo. And then we can also extrapolate that out. So here's the 52-week data where the placebo group crosses over to COSENTYX, and you can see this rapid response. And you'll notice even at the very beginning of the lines for COSENTYX, there's this rapid improvement. So we kind of know IL-17s work quickly in psoriasis. It's nice to know they do work quickly as well in HS. And then here's where I mentioned that even though that 24% of people who had been on a TNF before, we didn't see any difference between them and the biologic naive patients in terms of response, which is a nice thing to know for your patients when you do need to make a switch for someone, is that you're going to respond to this just as well as someone who has never had any treatment before for it or any biologic. 83% of patients at week 52 had no new draining tunnels, which is an important endpoint because this is where we're talking about preventing that damage and that progression of disease, which is really impressive. Then this is talking a little bit more about these exploratory endpoints at week 16, the high score 75, 90, and 100. So this is actually at week 52 in the patients who met the primary endpoint of a high score 50 at week 16. How are they doing at the end of a year? And like I said, we saw in that other curve, it kind of keeps going up throughout the past week 16. You see continued improvement, and you can see over 60% of those patients were seeing a 75% improvement, somewhere around 30 to 40, a 90% improvement, and even a portion we're seeing a 100% improvement. I see this in my practice where some patients respond really, really well, and it really controls their disease. And we present this data because the high score 50, you think of it as a 50% improvement, you have to remember it's at least a 50% improvement. So some patients are doing much better. So treating with COSENTYX can help your patients get that lasting relief at week 16. Some people were seeing fast results as early as week 2, which is really great. So a lot of times during that loading period, patients are already seeing results. And this is that AN50. So the AN50 is a lot like the high score in that it's a 50% reduction in abscesses and nodules, but it doesn't have those extra qualifiers of the no increase in abscesses and no increase in draining tunnels. So it's another tool that we look at sometimes to get just a different picture of the HS, because sometimes the high score can miss patients who maybe had one new tunnel but had a really great reduction in everything else. And so this shows that AN50 count at week 16 was over 50% for both of the trials. And this again is people getting at least a 50% reduction in the numbers. And then just like our data for the high score, we see that there's improvements to week 16, but then we see continued improvements all the way out to week 52. Now, you always have to remember that in these extension periods, sometimes you do have some dropout of patients, but I always say that's like real life. If you're not doing great at 6 months, I'm not going to keep you on the drug for a year hoping it'll work. I do usually give a drug like a biologic in HS 3 to 6 months, unless someone's really having no response at 3 or 4 months. I'm going to continue it for 6 to see where we get. And like we said here, about 71% of patients met that AN50 count at 1 year. So you kind of keep seeing that improvement throughout. But we switch at week 16 because we don't want to keep the placebo people on placebo that long. We saw reduced flare rates at week 16. So about 75% of people or more had no flares. I will point out the clinical trial definition right now for flare is a 25% or greater increase in your AN count compared to your baseline with a minimum of 2. So I do think this is valuable data to show that patients didn't get worse than their baseline in flare up. I am always a little careful when talking to about patients because this isn't what patients say for flare. Patients say flare is any increase from where they've been doing. So they'll talk about like, oh, I had a little flare. So these are kind of like significant flares. But it's good to know that patients didn't have flares by the trial definition. And then this is extending it out to a year. About 78% of patients had no flares in the Sunrise trial, which is great because that's again speaking to that lack of that long-term benefit. We're not seeing it taper off. And then this is really amazing. At 1 year, 70% of the patients who had moderate to severe pain reported mild or no pain. So this is a huge one because if you're like me, you go over all this treatment you're going to do for HS, and then the patient goes, okay, what are we going to do for my pain? And I have to go, oh, sorry, I should have mentioned this is going to treat your pain because it's going to treat the disease. Patients also reported improvements in quality of life as measured by the DLQI. We use DLQI for a lot of skin diseases. There actually is a newer tool called the HiSqual that's HS specific, but it wasn't available for this trial. And the DLQI patients, around 50% saw a 5-point reduction in DLQI. Normally, the clinical definition of a clinically meaningful improvement is 4-point reduction. So this was even a stricter criteria to say they had an improvement in their quality of life. So people get fast results from 2 to 16 weeks measured by that reduction in their inflammatory lesions. Then we saw those great 1-year numbers of a lot of patients having at least that 50% improvement, the no draining tunnels, the no flares, mild to moderate pain, or no to mild pain instead of moderate to severe, and improvement in their quality of life. Always important to balance everything with a little discussion of safety data. And luckily, it's a pretty easy discussion when it comes to COSENTYX because it was the largest trial in HS. Here you can see through week 16 with the 2 treatment groups and the placebo group, and you see the rates of adverse events overall were pretty similar between groups. We do have some AEs of special interest. So candida infections make sense when you block IL-17. That's one of the things it does in our body is fights candida infections. So that's something that we kind of expect could pop up with an IL-17 inhibitors. But importantly, we didn't see MACE events. Even that new onset inflammatory bowel disease was very low because there's been sort of questions about that with IL-17 inhibitors when they were tried to treat inflammatory bowel disease. And then extending it out to a year, the good thing is we don't see any new safety signals. We're seeing kind of the typical things that we saw at week 16. With the 1-year data, we like to highlight this inflammatory bowel disease because in the Sunny trials, the incidence of IBD, new onset IBD, was less than 0.3%. To put it in perspective, the prevalence of IBD in the general population is 1.3%, and in HS patients, it's 3.3% because we know it's a comorbidity and they share common inflammatory pathways. So we can't say it's protective, but it is good data to know that it doesn't seem to have a risk signal for new onset inflammatory bowel disease. I still ask patients, and if they have inflammatory bowel disease, I might go for a biologic that covers both of them. If they have a family history, it's a discussion we have, but it's definitely a relative contraindication, not absolute. So you can use it in patients if you're, need an option. We have lots of patients to back up the safety data, no boxed warning, no suicidal ideation behavior warning. The only lab monitoring that you need to do is the baseline TB test, and then you don't have to even do any kind of routine monitoring. And we, again, didn't see an increase toward that inflammatory bowel disease. There is, of course, anytime you modulate the immune system, an increased risk of infections, and they can be serious infections. We didn't really see that too much in the HS trials. You do want to be careful if someone has an infection when you're starting treatment. And again, I said evaluate for your tuberculosis at the outset of treatment at your baseline. Inflammatory bowel disease, they did see some signals in other disease states. But like we said, we didn't see a safety signal in the HS population. Still something to exercise with caution when you're prescribing to someone with inflammatory bowel disease. And then we did see in the post-marketing analysis some of these eczematous eruptions come out, but luckily they're seeing a dermatologist. They're pretty easy to treat, and very few patients had to stop their treatment because of that. And then, of course, anyone can have an allergic reaction, so hypersensitivity is possible. And then immunizations, don't give live vaccines. Luckily, adult patients don't need a lot of live vaccines. And the most common adverse events were nasopharyngitis, diarrhea, and upper respiratory tract infections, sort of things that happen if you talk to someone over the course of a year. So to get started on COSENTYX, Novartis has a lot of great support to help you. With the approval of HS, they introduced the UNO-Ready pen. If you remember when you used to give it when it came out for psoriasis, each dose was 2 shots. Now it's 1 convenient shot, so you can get the 300 milligrams. The initial dose is weekly for 5 weeks. Then you switch to every 4 weeks, but it is on label because I kind of glazed over that there were the 2 dosing regimens and they perform similarly. So in the FDA label, you start at Q4 week dosing and you can go up to Q2 weeks if the patient isn't having enough of a response. So that's nice that there's sort of this built-in backup plan. People usually ask me, when do you make the switch? So you've got them on the loading dose for the first 5 weeks, and you can kind of start to see the trend of their improvement and where it's going. Then you switch them over to the 4 weeks. So you have a 4-week dose at week 9. So usually after 1 or 2 4-week doses, I'm kind of assessing what's your progression going as? Have we plateaued and maybe we need to go to the 2? Are we still seeing sort of that steady improvement toward getting to our ultimate endpoint? So that's the good thing with the IL-17s like COSENTYX working so fast, is it kind of does allow you to make those decisions somewhat quickly. You don't have to wait months. You can do it more in a matter of weeks after 1 or 2 of the Q4 week dosing. If you do have a patient who is on the old dosing, you do have to send a new prescription for the UNO-Ready pen because it's a different NDC number. So I've sort of switched patients over as I've seen them back. 98% of patients in a psoriasis study reported no pain with the injection. The cap does not have natural rubber latex, which is nice in case that's a concern for people. And it's really a positive experience from patients. Great coverage, first or second line biologic with a lot of private insurers, Medicare and Medicaid. So that's good to get access for patients. Novartis also has a covered till you're covered program where your patients who have private insurance can get drug for up to 2 years for free while you're getting the prior auth gone, so that doesn't delay them getting started. They have great copay offers to help privately insured patients. Of course, those don't apply to government insured patients. And then access and reimbursement managers, Ready, Set, COSENTYX, just great resources to help your patients get on drug and stay on drug. So really happy to talk about HS. If we have still a couple minutes for questions, I'm happy to take some questions.
Thank you, Dr. Daveluy. That was wonderful. I learned a lot. Every time I listen to you, I learn a lot. So hopefully our audience did too. We do have maybe a minute or 2 for a question. Why is the dosing difference for HS versus psoriasis?
So that's a really good question. We sort of learned with HS, it seems like the inflammatory burden is a lot higher. So you'll remember like adalimumab, the dosing was more intense. It's more like the ulcerative colitis and Crohn's dosing. And with HS, we saw, the Q4 week dose is the same as psoriasis, but they did approve that Q2 week dose. So if you have patients who aren't getting an adequate response, you can kind of up the dose, which is nice. Like I said, it's nice to have that built-in backup. And I will often tell it to patients when I'm starting them on it, because a lot of times HS patients have had such a difficult journey that they can find it hard to find hope that something's going to work. So it's nice when I tell them, all right, we're going to start this. And if we need to, we can even adjust the dose. It's approved.
Wonderful. Thank you so much. We're right at 6:30, our program tonight for 30 minutes. I thank you so much. Now that we are done with the Novartis program, our next, I thank you, our supporter Novartis, to make this happen tonight. And we join us with another webinar on Thursday night at 7 p.m. Dr. Jim Del Rosso will talk a little bit about acne as well as Winlevi. Thank you so much and have a good night. Thanks, everyone. Good night.
Thanks, everybody.